Hi, I'm Hope Rugo, a breast medical oncologist at the University of California, San Francisco's Comprehensive Cancer Center, where I'm a professor of medicine and director of breast oncology and clinical trials education. Today, I want to talk to you about the remarkable data from Destiny Breast 04 evaluating the antibody drug conjugate Trastuzumabe Deruxtecano in patients with HER2-low metastatic breast cancer. Trastuzumabe Deruxtecano is a novel antibody drug conjugate, our second generation ADCs. This drug uses a biosimilar trastuzumab as the backbone, and then the payload is a topoisomerase inhibitor called deruxtecan. TDXD, and this is not for all new ADCs, but for several of the newest drugs that are approved, TDXD has a high drug to antibody ratio of 8 to 1, with a potent and very effective payload, but also a novel delivery system with a linker that is plasma stable. And the toxin itself is membrane permeable, which is thought to lead to a so-called bystander effect, where the drug can leak out the payload from the tumor cell that's targeted and cause death of neighboring tumor cells. And this is really important as we're using antibodies to target cells that have relatively low expression of the target. In an initial umbrella trial that looked at different groups of patients with different cancers and different HER2 expression, TDXD showed, of course, remarkable efficacy in refractory HER2 positive disease, leading to dramatic results from a phase 3 trial, but also it showed efficacy in patients who had disease that was not considered HER2 positive, but HER2 low. And that was defined as having immunohistochemistry of 1 plus or 2 plus for HER2, but no gene amplification, and specifically for the patients who have 2 plus IHC findings. So that translated into the ideas for Destiny Breast 04, a phase 3 trial. Now, in that initial umbrella study, there weren't very many patients with triple negative breast cancer, and it was seen that HER2 low status was much less frequent in triple negative compared to hormone receptor positive disease. So the trial was designed with a primary endpoint looking at the efficacy of trastuzumab deruxtecano or TDXD in patients with metastatic hormone receptor positive disease. But there was also an exploratory subset looking at patients who had triple negative HER2 low disease as well. But the primary endpoint was in hormone receptor positive disease. And patients who were eligible for Destiny Breast 04 had received 1 to 2 prior lines of chemotherapy in the metastatic setting and at least 1 line of endocrine therapy. And CDK4/6 inhibition was not required, but about 70% of patients had received prior CDK4/6 inhibitors. The median lines of chemotherapy in this patient population was 1. Patients were randomized 2 to 1 to receive TDXD, which is given intravenously every 3 weeks, or treatment of physician choice that included a menu of chemotherapy options of capecitabine, eribulin, gemcitabine, paclitaxel, or nab-paclitaxel. The total number of patients randomized to TDXD was 331 and 163 for treatment of physician choice. In the subset of patients with triple negative breast cancer, there were 58 patients enrolled, just 18 to the treatment of physician choice and 40 patients to TDXD. The results from Destiny Breast 04 were presented at ASCO in 2022 and published in the New England Journal of Medicine. And I'll share with you those results as well as a subsequent subset analysis that was presented at ASCO 2023. So what was shown was a remarkable improvement in progression-free survival in patients with hormone receptor positive disease, as well as a marked improvement in overall survival. This was really quite interesting because the absolute improvement in PFS was 4.7 months. The median in TDXD treated patients was 10.1 months with a hazard ratio of 0.51. But the overall survival difference was even greater at 6.4 months, with a median in patients receiving TDXD of 24 months and hazard ratio 0.64, and both of these findings were highly statistically significant. It's interesting that almost all of the complete responses were seen in patients who received T-DXd, and partial responses went from a whopping 16% for treatment of physician choice to 49% with T-DXd. And this was really very, very impressive, doubling of the clinical benefit rate, and of course, a longer duration of response. In a subset analysis that was presented at San Antonio 2022, the forest plots show that essentially with all characteristics that you can think of, T-DXd was better than treatment of physician choice. And that included the small number of patients who had baseline brain metastases, older versus younger patients, patients who had 1+ versus 2+ HER2 low disease by immunohistochemistry, whether patients had 1 or 2 prior lines of therapy, although the majority, as I mentioned, the median was 1 line of prior chemo, whether they had visceral disease or not, disease burden that was low or high, CDK4/6 inhibitors, and various prior treatments, which were interesting. There was a lot of interest in whether or not patients might have more toxicity if they had IHC 2+ versus 1+ disease, or if they had had prior CDK4/6 inhibitors or not, but there was no difference in the toxicity in those patients at all. And also, patients with rapid disease progression, relative endocrine resistance seemed to benefit similarly from T-DXd. So that was really encouraging. In terms of this exploratory subset in hormone receptor negative disease, again, tiny group of patients, triple negative, HER2 low, but the improvement in PFS was 5.6 months and overall survival 9.9 months, really dramatic. The median overall survival in triple negative disease, still not what we would like to see, but it went from 8.3 to 18.2 months. So a big, big difference and clinically very relevant that led to regulatory approval of T-DXd across different receptor status. So hormone receptor positive or negative. Although again, this was an exploratory small subset of the overall the overall trial population. At ASCO, before we talk about safety, we also saw data which was really interesting, actually, looking at patients based on a number of different genetic variables. In this subset analysis, the efficacy was evaluated based on intrinsic subtype, so looking at luminal A or B or HER2 enriched, and patients who had ESR1 mutations, PIK3CA mutations, and then a panel of resistant markers to CDK4/6 inhibitors. And this is really very impressive, looking at both the overall response and progression-free survival. The benefits are very clearly for T-DXd versus TPC, with big differences regardless of these different findings. I would say that, in intrinsic subtypes, it's actually really interesting because you can see how patients do based on their intrinsic subtype. And the patients who receive treatment of physician choice for HER2 enriched disease has actually the worst outcome compared to those who had other luminal type subtypes, as you would potentially expect. But if you looked at the difference between patients who received the Trastuzumabe Deruxtecano or T-DXd based on HER2 enriched, the hazard ratio was 0.15. Again, this was 20 versus 12 patients, so this is totally exploratory, but I think quite fascinating data and contributes to what we know about T-DXd. So anytime we have a new drug, I think it's really important for us to understand the toxicity. And of course, T-DXd has unique toxicity. The most common toxicity is nausea, and it's really important to understand that. We have classified it in the NCCN as highly emetogenic. We use a triple drug regimen as the initial treatment. And in the small population who don't have nausea, you can tailor back the pre-medications that you give patients. But generally, we find that the triplet is helpful for patients. And we also use the oral antipsychotic olanzapine during the post-treatment period to try and reduce nausea, because sometimes that can be delayed, occurring out to 7 to 10 days for some patients. In some patients where you've tried everything and they're still nauseated, dose reduction works really well in addition. Interestingly, with this drug, we don't see a lot of bone marrow suppression, and that's really great. I mean, you have patients who've been on T-DXd for a year and they're not anemic, which is really quite dramatic. There is a subset of patients who have relatively, worse bone marrow function, who do get neutropenic, and those patients I've found growth factors to work really well. Mild thrombocytopenia can be seen as well, but it's quite uncommon. we don't see a lot of diarrhea, but there are patients who are quite fatigued, even in the absence of anemia. And again, their dose reduction works well. I will mention that some patients do have hair loss that can be significant. So it's important to warn patients, although it is only about a third of patients who have alopecia. You don't want patients to not be aware of the fact that they could lose, more than 50% of their hair over time. It's not like anthracyclines where the hair all falls out, but it just happens gradually over time for these patients. Obviously, although uncommon, the most critical toxicity to know about in terms of serious impact on patient life is interstitial lung disease or pneumonitis. In Destiny Breast 04, that occurred overall in 12% of patients. It's a relatively early event with just under 90% of the events occurring for the first time in the first year after starting treatment. And 3 patients died of interstitial lung disease who received TDXD on Destiny Breast 04. So that, I think, highlights the importance of monitoring for these patients and early intervention. Our recommendations are that patients hold drug for asymptomatic ground glass opacities in lungs. So we do recommend CT, diagnostic CT, and it can be non-contrast monitoring of patients, particularly early in their course of disease. For grade 2 or symptomatic ILD, drug should be discontinued permanently. For grade 1 ILD, we treat with 0.5 milligrams per kilogram of prednisone, and then we repeat the scan at 3 weeks and taper the steroid. Patients can restart drug if they have a resolution or almost complete resolution of ground glass opacities and no symptoms. I think the steroids really help with the faster resolution of the symptoms, so of the findings on scan in these asymptomatic patients. So it is, I think, an important part of treating patients in the best way. For symptomatic ILD, we use 1 milligram per kilogram of steroid. And it's really important that that be initiated early because we have had really complete resolution in all patients when we've taken this really careful monitoring and treatment approach. You don't want to wait 3 months when you start TDXD to get your first CT scan. We usually get the CT within 6 to 9 weeks after we start therapy, and we continue that at least for the first few months of therapy before we go to a less frequent imaging. And you should never do imaging less frequently than every 3 months, at least with a non-contrast CT. You don't have to get all your scans at the same time. It's just really important to monitor for this lung toxicity because we can prevent mortality. In a pooled analysis presented last year by Powles et al. In ESMO Open, different risk factors were identified, including patients of Japanese origin, but also patients who'd received more prior therapy, had underlying pulmonary disease, and importantly, patients who had renal insufficiency had a higher risk. So that's really important as well. But we found that with careful monitoring, this makes no difference. The last thing that I really want to address is how you determine HER2 low status. It's very controversial and it can waver a lot. It can be present, absent, dependent, present again with serial biopsies. And people are looking at better ways to test IHC low. So I think that, looking at Destiny Breast 04 and response is one helpful way to try and understand how to apply this to clinical practice. And basically, there were only 22% of samples that were discordant between local and central testing in Destiny Breast 04, which is really encouraging. And 88% of those discordant samples were IHC 0 by central scoring. So, mostly were pretty good by local scoring. And then a lot of the samples were kind of old. So that was actually really helpful too. It didn't really matter whether the samples were older or newer in terms of response. 31% or a third of the samples were collected from 2014 to 2018. So that's also encouraging. If you have a sample that's HER2 low at any point during a patient's evaluation of their cancer, you can reasonably safely use the drug. And of course, now we're testing the efficacy of TDXD in patients who haven't received prior chemotherapy for metastatic hormone receptor positive disease that's HER2 low. By central determination. But in that study called Destiny Breast 06, where 850 patients are randomized, 150 have been randomized to have ultra low disease. So not 0, but not 1+ by ASCO CAP criteria. This study has completed accrual and we hope to see results in the near future. Thanks for listening, and I hope you found this helpful.